Vaginal fornices gradually disappear as the cervix shrinks after the menopause. Vagina becomes narrow and its epithelium becomes pale, thin, and dry, gets easily infected, causing senile vaginitis. Vulva atrophies, vaginal orifice narrows, this can cause dyspareunia. The skin of labia minora vestibule becomes thin, pale, and dry. Apart from atrophy of the genital organs, general disturbances that develop are almost certainly caused by alteration in the endocrine balance maintained during the childbearing period. Fat is deposited on the breasts, hips, and abdomen. Although mammary glandular tissue atrophies, deposition of fat often makes the breast more pendulous. Menopausal symptoms. They can be sudden cessation of menstruation, gradual diminution in the amount of blood loss with each regular period until menstruation stops, gradual increase in the intervals between periods until they cease for a period of at least 1 year. Although by definition menopause is said to have set if the menorrhagia lasts for an year, a woman who bleeds after a gap of 6 months is considered to have postmenopausal bleeding and should be thoroughly investigated. What are the early features of menopause? They are hot flushes, sweating, insomnia, headache, psychological imbalance, cancer phobia, dyspareunia, decreased libido, pseudocysis, irritability, depression, insomnia, tiredness, lack of concentration, loss of memory, urinary stress incontinence, dyspareunia. Hot flushes. It is the most common symptom experienced by women after menopause. About 60 to 70% women go through their menopausal period without problems. The rest need guidance and treatment. Hot flushes are the waves of vasodilation affecting the face, the neck, and these last for 2 to 5 minutes each. These are followed by profuse sweating. These flushes occur several times a day but are more severe during the night and can disturb sleep. The hot flushes are sometimes preceded by headache. Palpitation and anginal pains may be felt. Mental depression due to disturbed sleep or otherwise irritability, lack of concentration are noticed. With the passage of time, the frequency and severity of the flushes diminish over a period of 1 to 2 years. They are caused by noradrenaline, which disturbs the thermoregulatory system. Estrogen deficiency reduced hypothalamic endorphins, which release more norepinephrine and serotonin. This leads to inappropriate heat loss mechanism. Other symptoms. Some women develop condition of pseudocysis when they fear pregnancy and attribute amenorrhea and increased abdominal girth to pregnancy. Cancer phobia may also develop. Neurological. Vasomotor symptoms. Paresthesia may take the form of sensation of pin and needle in the extremities. Libido. Sexual feeling and libido may increase in some if they feel happy to get rid of menstruation and fear of pregnancy. Many, however, notice decreased libido after menopause. Urinary symptoms such as dysuria, stress and urge incontinence, recurrent infection. Genital symptoms such as dry vagina, dyspareunia, loss of libido, fecal incontinence, thyroid dysfunction may occur. Urinary tract symptoms. Estrogen deficiency can cause urethral caruncle, dysuria with or without infection. Urge and stress incontinence. The stress incontinence is caused by poor vascularity, tone of internal urethral sphincter. These urinary symptoms are clubbed together under the term urethral syndrome. Genital symptoms. Atrophic vagina also reduces vaginal secretion, and dry vagina can cause dyspareunia. Loss of libido adds to sexual dysfunction. Rarely, senile vaginitis can cause vaginal bleeding. Prolapse of genital tract and stress incontinence of urine and feces are mostly menopause related. Neurological. Depression, loss of memory, irritability, poor concentration, tiredness, poor sleep, and pre-dementia. Late effects of menopause are arthritis, osteoporosis, fracture, or backache, cardiovascular accidents such as ischemic heart disease, myocardial infarction, atherosclerosis, and hypertension, hypothyroidism, diabetes, stroke, skin changes, Alzheimer's disease, anocolonic cancer, tooth decay, prolapse of genital tract, stress urinary incontinence of urine, fecal incontinence, cataract, glaucoma, macular degeneration. Osteoporosis. It is an incipient, slowly progressing skeletal disorder characterized by microarchitectural deterioration of bone mass, resulting in increased fragility and predilection to fracture in the absence of significant trauma. About 15% elderly women suffer from osteoporosis, and almost 3 times as many suffer from osteopenia, deficient bone mass. Both osteopenia and osteoporosis predispose to fracture. Hip joints are often associated with high rate of mortality. Wrist and hip joints are particularly affected. With increasing longevity of women in India, the medical practitioners will be called upon more often to care for osteoporosis related problem. It is defined as a condition in which there is a fall in bone mass exceeding 2.5 standard deviation below mean for young adults. WHO defined low bone mass as osteopenia and osteoporosis on the basis of axial skeleton bone mineral density. Osteopenia is bone mineral density between 1 and 2.5 standard deviation below young adult mean peak bone mass, and osteoporosis as BMD, which is 2.5 standard deviation or more below the standard adult mean values. Pathophysiology. Bone is not an inert supporting tissue. Bone remodeling takes place constantly. At cellular level, bone remodeling is a balance between bone resorption, osteoclastic activity, and bone formation, osteoblastic activity, whereas main functions of the osteocytes and lining cells are metabolic, subserving the nutrition of the bone and the maintenance of calcium homeostasis. After the cessation of adult growth, the skeleton consolidates to reach peak bone mass at the age of 35 to 40. Thereafter, a slow subsequent age related loss of bone mass occurs in everyone at the rate of zero point 0.4 annually. But women are additionally exposed to an accelerated rate of bone loss during the perimenopausal age and the initial 5 to 8 years of early menopause. Estrogen deficiency is the dominant factor contributing to osteoporosis in women. Additional factors are calcium and vitamin D deficiency. Other risk factors are family history of osteoporosis, low calcium intake, and diet. Smoking, excessive caffeine and alcohol intake, early menopause, lower weight, surgical menopause following hysterectomy with or without oophorectomy, radiation menopause, women on GnRH, heparin, corticosteroid, danazole, clomiphene, thyrotoxicosis, sedentary lifestyle, diabetes, cardiovascular disease. Estrogen is cardioprotective by maintaining high level of HDL and lowering the LDL and triglycerides. Estrogen deficiency therefore predisposes to atherosclerosis, ischemic heart disease, and myocardial infarction. Stroke. The incidence of stroke also increases in menopausal women. Skin. Collagen content is reduced, causing skin to wrinkle. The feminine fever forever thought applies to estrogen cream to delay the age related skin changes. Alzheimer's disease. It is believed that Alzheimer's is precipitated by estrogen deficiency at menopause, and hormonal therapy is beneficial in preventing or delaying its onset. Endocrine system. Mild virilization, as seen in the form of hirsutism, is probably because of androgens produced from the adrenals and obesity, particularly deposition of fat around the hips. Hypothyroidism with low basal metabolic rate, high cholesterol level, dryness of skin, brittleness of hair, lack of concentration are noticed in some menopausal women. Pyometra. After years of menopause, a woman may develop senile pyometra caused by cervical stenosis, needs drainage by cervical dilatation under general anesthesia. Approach to menopausal women. History of the various symptoms. General examination including blood pressure, palpation of breast, weight, and hirsutism. Pelvic examination, pap smear, blood sugar, lipid profile, ECG. Mammography, pelvic ultrasound. Bone density study, DEXA, is a quick test with less radiation. Estrogen FSH levels to decide the need for HRT. Endometrial biopsy is in women on HRT and tamoxifen. Management. It includes counseling. The woman often develops phobia about pregnancy and cancer. It is duty of gynecologist to convince her after thorough examination and investigation. Mild tranquilizers. These relieve women's anxiety, sleeplessness, and depression. Antidepressants such as sulpiride may be needed. Antidepressant drugs, venlafaxine 30 to 150 mg daily, paroxetine 1 to 20 mg daily, gabapentin 300 mg 3 times a day. Hormone replacement therapy. Not all women require HRT. Besides, HRT doesn't suit all. It may cause complications and be harmful. However, it is logical to prescribe HRT and not withhold when one needs it with minimal effective dose for the shortest duration under supervision. Who needs HRT? Symptomatic women who suffer from estrogen deficiency as therapeutic measure. High risk cases for menopause related complications such as cardiovascular disease, osteoporosis, stroke, Alzheimer's, colon cancer. Premature menopause spontaneously or following surgery like hysterectomy and tubectomy. The surgical procedures disturb and compromise the blood supply to the ovaries. Menopause caused by radiotherapy, chemotherapy for cancer, especially alkylating agents. Gonadal dysgenesis in adolescents. Uses of HRT for short term are hot flushes, vasomotor symptoms, dyspareunia, libido, urethral syndrome. In long term, they are used to treat osteoporosis, cardiovascular complication, and Alzheimer's disease. In osteoporosis, HRT is the cornerstone in prophylaxis and treatment of osteoporosis. After menopause, women loses an average 3% bone mineral density every year, causing osteopenia and eventually osteoporosis and fracture of the vertebrae, femur, and the wrist. Trabeculated bone is most commonly affected. Prophylaxis of osteoporosis. Estrogen hormone therapy, estrogen plus progesterone therapy, tibolone, raloxifene, soya extract, bisphosphonates for late osteoporosis, calcitonin, hormone, and diet. Cardioprotective effects of hormone replacement therapy. Estrogen deficiency increases the risk of atherosclerosis, ischemic heart disease, and angina in postmenopausal women. Estrogen is therefore cardioprotective in prevention of cardiovascular disease. It also increases HDL and decreases LDL, cholesterol, and triglyceride. Estrogen is most effective when taken orally as far as its effect on lipid profile is concerned. Estrogen and tibolone are strongly cardioprotective in menopausal women. However, a woman with previous ischemic heart disease does not benefit from HRT and its use is not recommended. Drugs dosage and route of administration. Estrogen therapy. Short term therapy is required to relieve women of hot flushes, night sweat, palpitation, disturbed sleep for a period of 3 to 6 months. Oral Primarin E1 natural equine conjugated estrogen in the dose of 0.375 milligram or 0.625 milligram daily, increasing to 1.25 milligram if necessary. Ethinyl estradiol 0.01 mg, micronized estrogen 1 to 2 mg, or evalon 1 to 2 mg are effective. Progestogen such as dufaston, medroxyprogesterone 10 mg, or primolut N 2.5 mg daily for 10 to 12 days each month should be added to prevent endometrial hyperplasia and carcinoma. This therapy can still cause endometrial hyperplasia in 5% and atypical hyperplasia in 0.7% of the cases. Because of this, some prefer to give a combined hormone therapy, FIMET, containing 2 mg 17 beta estriol and 1 mg norethisterne acetate, which is known to cause endometrial atrophy. Progesterone is not required in hysterectomized women. Cyclical combined HRT causes cyclical bleeding. Period free HRT can be attained if combined hormones are taken continuously. Dyspareunia, urethral symptom, and senile vaginitis respond well to local estrogen cream, which is preferred over the oral therapy. Estriol base cream, half gram, is applied every day for 10 to 12 days each month for a period of 3 to 6 months until the symptoms disappear. Each ring, a vaginal ring, releases 5 to 10 mcg estrogen and is 90% effective over a period of 3 months. Long term therapy is beneficial in delaying the osteoporosis, reducing risk of cardiovascular disease in postmenopausal women. Oral route. Orally combined estrogen get extensively metabolized into estrogen in the intestine and liver so that only 10% reaches the systemic circulation is as estradiol. Larger doses therefore need to be given orally compared to the non-oral route. This is known as first pass effect and also increases certain liver proteins, altering the clotting factors and increases the secretion of renin. Transdermal patch or estraderm. It avoids the first pass effect of the liver metabolism and the hormone reaches the systemic circulation as estradiol. The risk of thromboembolism episode and probable hypertension is eliminated. It reduces serum triglyceride levels as well. Estraderm patch contains 3 to 4 mg estradiol, releasing 50 mcg per day. The disadvantage of skin reaction with the alcohol based patch is now avoided by newer transdermal system, but it cannot be reapplied after being taken off the skin during the bath. The patch needs to be changed twice a week. The cost prohibits women from using them. The advantages and disadvantages of oral and transdermal route of estrogen. Oral route has advantages of being cheaper, easy to take, can be withdrawn quickly in the presence of side effect, good for lipid profile and cardiovascular protection. Disadvantages are higher doses required, first pass effect in the liver, daily intake should be there. Tablet contains lactose, not suited to women who are allergic to lactose. higher incidence of side effect, increased risk of hypertension and thromboembolism. Transdermal patch has the advantages of low dose estradiol, avoids first pass metabolism and liver metabolism, reduces the triglyceride, no thromboembolic risk or hypertension risk. Disadvantage are it is costly, not tolerated in warm climate, and it has variable absorption. Vaginal cream. Estriol cream is used in urethral syndrome and dry vagina. About 1 to 2 gram is applied daily for few days. Vaginal ring. It is effectively achieved by inserting vaginal ring that releases 0.0075 mg of 17 beta estradiol daily for 90 days. Implant containing 25 to 50 mg estradiol is effective for 6 months each and maintains the E2 levels at 50 to 60 picogram per ml. Minor operation is required for insertion and removal. It is suitable in hysterectomized women. Intranasal 300 mcg estrogen raises the level of hormone in 30 minutes and becomes effective. However, breakthrough bleeding, sneezing, itching occur in 1 to 3% cases and 55% have stopped the therapy by the end of 1 year. Estrogen therapy reduces the incidence of fracture by 50% at the end of 5 years. Similarly, cardiovascular complications have been reduced by 40 to 50% with estrogen therapy. Risks of HRT usage are endometrial cancer, breast cancer, ovarian cancer, thromboembolism, lipid profile dysfunction, gallstone, liver dysfunction. Vaginal bleeding with continuous HRT is more common if the therapy is started within 1 year of menopause and may last up to 6 months. After first year of menopause, there is less risk of vaginal bleeding. Persistent vaginal bleeding requires endometrial biopsy. Gabapentin is a non-hormonal anticonvulsant that reduces hot flushes by 50% if given in a dose of 900 to 2400 mg daily. Dizziness, drowsiness, tiredness, headache, blurred vision, dry mouth, memory problem gradually disappear after a week or so. Thromboembolism, endometrial cancer, if E2 is taken alone, the risk lasts after for 10 years after stoppage of therapy. Breast cancer is due to progestogen if HRT is taken for more than 5 years. The possibility of coronary artery disease in a woman with cardiovascular disease has caused great concern regarding the use of HRT. HRT is contraindicated in these cases. Increased risk of ovarian cancer. Progestogen. They are used for 10 to 12 days in each cycle to avoid the risk of endometrial hyperplasia and cancer in non hysterectomized women. The risk of endometrial hyperplasia is reduced to 4% if given 12 days in each cycle. It does so through the enzyme 17 beta hydroxy dehydrogenase, which inactivates the E2 and controls the mitotic activity within the endometrial cells. The drugs used are norethistérone 2.5 mg, medroxyprogesterone, and dufaston 10 mg. Progesterone implants are also available for those who are intolerant to estrogen. Mirena IUCD containing levonorgestrel is inserted for 5 years in hormone replacement therapy program. Micronized progesterone is not useful in HRT. Progesterone role includes prevent endometrial hyperplasia, improves the bone mineral density. Implant may replace estrogen. Other drugs are tibolone, raloxifene, soya, bisphosphonate. Bisphosphonates such as etidronate, telludronate reduce the bone reabsorption through the inhibition of osteoclastic activity. Etidronate 10 mg per kg body weight is given for 2 weeks followed by a gap of 2 to 3 months. This course is repeated for 10 such cycles.